Today, I'm going to educate cancer registrars about the diagnosis and screening of prostate cancer. My intent is not to give medical advice to the general public. My name is Babette Langeneckert, and I will be the presenter for this topic. I would like to acknowledge the source of our funding. The Missouri Cancer Registry and Research Center is supported in part by cooperative agreement between the Centers for Disease Control and Prevention and the Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and University of Missouri. Cancer screening involves testing to find cancer in people before they have symptoms. For some types of cancer, screening can help find cancers at an early stage, where they are likely to be easier to treat. Prostate cancer can often be found early by testing for a prostate specific antigen, PSA, levels in a man's blood. Another way to find prostate cancer early is the digital rectal exam, DRE, in which the doctor puts a gloved, lubricated finger in the rectum to feel the prostate gland. If the results of either one of these tests are abnormal, further testing is often done to see if a man has cancer. If prostate cancer is found as a result of screening with the PSA test or DRE, it will probably be at an earlier, more treatable stage than if no screening were done. Our agenda goals for today will be to understand prostate anatomy, symptoms of prostate cancer, prostate specific antigen, PSA, digital rectal exam, DRE, prostate biopsy, Gleason Score, CT scan, and bone scan. First, let's take a look at prostate anatomy. The prostate and seminal vesicles are part of the male reproductive system located just below the bladder, noted here in red, and in front of the rectum. It's about the size of a walnut and weighs about an ounce. The prostate surrounds part of the urethra. The urethra is a tube that carries urine from the bladder out through the penis. This is why men with an enlarged prostate have difficulty urinating, as it can disrupt the flow of urine from the bladder. The prostate gland produces the seminal fluid that nourishes and transports sperm. During ejaculation, the sperm from the testicles moves into the urethra. At the same time, fluid from the prostate and seminal vesicles also moves into the urethra. This mixture of semen and fluid from the prostate and seminal vesicles forms the ejaculate that passes through the urethra and out the penis. When prostate cancer occurs, it starts in the prostate gland and occasionally spreads to the seminal vesicles. So what are some of the symptoms to look for when considering a possible diagnosis of prostate cancer? Whether to test healthy men with no symptoms for prostate cancer is considered to be controversial. Medical organizations don't agree on the issue of screening and whether it delivers benefits. Some medical organizations recommend men consider prostate cancer screening in their 50s or sooner for men who have risk factors for prostate cancer. Prostate cancer may cause no signs or symptoms in its earliest stages. Prostate cancer that's more advanced may cause signs and symptoms such as trouble urinating, decreased force in the stream of urine, blood and semen, discomfort in the pelvic area, bone pain, and erectile dysfunction. When symptoms do occur, they can be like those of an enlarged prostate or benign prostatic hypertrophy. Prostate cancer can also cause symptoms unrelated to BPH. A transurethral resection of the prostate, or TURP, is most often done to relieve symptoms caused by benign prostatic hypertrophy. Patients in whom prostate cancer is suspected and who have lower urinary tract symptoms with a previously negative transrectal ultrasound and biopsy result can undergo TURP, which results in immediate improvement in bladder outlet obstruction and early diagnosis of clinically significant transitional zone prostate cancer. An instrument called rectoscope is passed through the urethra. It contains a lighted camera and electrical wire loop that cuts tissue and seals blood vessels. It is used to cut away the pieces of prostate tissue that are bulging or blocking the urethra. The pieces are flushed into the bladder and then drained out through the urethra. Note, prostate cancer may be found in tissue obtained from a TURP. In this situation, the TURP will be part of the clinical assessment. Per the AJCC 8th edition, Chapter 58 for prostate, pathological classification requires a radical prostatectomy. A TURP is not included in the criteria for pathological staging. What is the PSA test? The PSA test was originally approved by the FDA in 1986 to monitor the progression of prostate cancer in men who had already been diagnosed with the disease. In 1994, the FDA approved the use of the PSA test in conjunction with a digital rectal exam to test asymptomatic men for prostate cancer. Prostate Specific Antigen is a glycoprotein produced by normal as well as malignant cells of the prostate gland. The PSA test measures the level of PSA in a man's blood. For this test, a blood sample is sent to a laboratory for analysis. The results are usually reported in nanograms of PSA per milliliter of blood. Elevated PSA by itself is not diagnostic of cancer. The chance of having prostate cancer goes up as the PSA level goes up, but there is no set cutoff point that can tell for sure if a man does or doesn't have prostate cancer. Many doctors use a PSA cutoff point of 4 nanograms per milliliter or higher when deciding if a man might need further testing, while others might recommend it starting at a lower level, such as 2.5 or 3. Most men without prostate cancer have PSA levels under 4. Still, a level below 4 is not a guarantee that a man doesn't have cancer. Men with a PSA level between 4 and 10 have about a 1 in 4 chance of having prostate cancer. If the PSA is more than 10, the chance of having prostate cancer is over 50%. Prostate Specific Antigen, PSA. The PSA test is a very important tool. It helps find prostate cancer early, before it spreads. When found early, it can be treated early, which helps stop or slow the spread of cancer. A risk of a PSA test is that it may miss detecting cancer, a false negative, or the test may be false positive, suggesting something is wrong. A false positive result may lead to a biopsy that isn't needed. The test might also detect a very slow-growing cancer that a doctor may determine will not need treatment in specific individual situations. Serum PSA is the most sensitive tumor marker for monitoring individuals with prostate cancer, including progression of disease and response to therapy. Although originally not intended to be a screening test, this relatively simple blood test has become a very common method of detecting new prostate cancer in its earliest stages. PSA can be totally negative when prostate cancer is found on digital rectal exam. In such cases, PSA will not be helpful in monitoring for a recurrence. Let's take a look at the site-specific data item for the PSA lab value. This data item is required for prognostic stage grouping in AJCC 8th edition, Chapter 58 for prostate. It affects the stage group in most cases. Note, serum PSA is not the same as free PSA or precursor PSA. Do not record values from either of these tests in this field. Registrars can record the lab values with a decimal point as part of the code. The entered value must be right justified in the field and padded with spaces to the left, if necessary to fill the field. User software will usually justify and pad the value automatically for the registrar. Record the lab value as one less than stated when the value is reported as less than X, and as one more when stated value is reported as more than X. One less or one more may refer to a whole number or a decimal, depending on the code structure of the field. For example, PSA stated as less than 5, record as 4.9. Note, a discrepancy between the PSA documented in the lab report and the PSA documented by the clinician may arise due to the clinicians adjusting the PSA value. Certain medications for benign prostatic hypertrophy decrease the PSA. If there is documentation by a clinician within the medical record of an adjusted PSA value, record the adjusted value. Record to the nearest tenth in nanograms per milliliter the last pre-diagnosis PSA lab value prior to diagnostic biopsy of prostate and initiation of treatment. When the value in the medical record does not provide the expected decimal digit, it is expressed as a whole number, then enter the value followed by a decimal point and a 0. If the PSA lab value is recorded in 100ths, 2 digits after the decimal point, then the last digit must be rounded. The general rounding rules are: if the last digit is 0 to 4, round down. If the last digit is 5 to 9, round up. Examples: PSA of 7.2, enter 7.2. PSA of 10, enter 10.0. PSA of 8.56, enter 8.6. PSA of 110.35, enter 110.4. In addition to the actual values, codes are defined for situations such as value unknown, test done but results not chart, and other special cases. For example, XXX.7, test ordered, results not in chart. XXX.9, not documented in medical record. PSA lab value not assessed or unknown if assessed. The prostate can be examined with a digital rectal exam. The doctor or nurse inserts a gloved, lubricated finger into the rectum to examine the prostate, which is adjacent to the rectum. If the doctor finds any abnormalities in the texture, shape, or size of the gland, further tests may need to be performed. PSA testing combined with DRE helps identify prostate cancers at their earliest stages. If the screening results are abnormal, the doctor may do more tests, such as an ultrasound, MRI, or a biopsy. Most prostate cancers occur in the peripheral zone. Whether or not a tumor is large enough to be palpable is an important clinical indicator. Now we'll look at the types of prostate biopsy procedures. Prostate biopsy samples can be collected in different ways. A prostate biopsy may involve passing the needle through the wall of the rectum, a transurethral biopsy. This is the most common way of performing a biopsy. Transrectal ultrasonography uses sound waves to create images of the prostate. This ultrasound images are also used to guide the prostate biopsy needle into place. This is a non-targeted method of taking systematically spaced samples across the prostate gland to find a cancer. Because this method can potentially miss areas of cancer, doctors may then overtreat a patient with low-grade disease, fearing there is high-grade disease they missed. Or if an aggressive cancer is missed, a patient may be undertreated. Once the area is numbed and the biopsy device is situated, the doctor will retrieve thin, cylindrical sections of tissue with a spring-propelled needle. The doctor may target a suspicious area to biopsy or may take samples from several places in the prostate. Generally, 10 to 12 tissue samples are taken. Since the mid-1980s, transrectal ultrasound biopsy has been used to diagnose prostate cancer in essentially a blind fashion because prostate cancer cannot be seen on ultrasound due to poor tissue resolution. However, multiparametric magnetic resonance imaging has been used since about 2005 to better identify and characterize prostate cancer. Prostate biopsies performed utilizing information from MR imaging provides more detailed images of the prostate than is possible with ultrasound. Before the biopsy, prostate MR images are examined, sometimes also with the help of computer-aided detection software to pinpoint specific areas that may require further evaluation. MR-guided in-bore biopsy can be performed using either a transperineal or transrectal approach. Both methods typically utilize software to guide the course of the needle to the desired position within the prostate. Transperineal biopsy. A biopsy procedure with a higher rate of cancer detection is template prostate mapping, or transperineal template guided mapping biopsy, whereby typically 50 to 60 samples are taken of the prostate through the outer skin between the rectum and scrotum to thoroughly sample and map the entire prostate through a template with holes every 5 millimeter, usually under a general or spinal anesthetic. A small cut is made in the area of skin between the anus and scrotum. The biopsy needle is inserted through the cut and into the prostate to draw out a sample of tissue. An MRI or CT scan is generally used to guide this procedure. It's recommended for men who are suspected of having prostate cancer, but who may have inconclusive test results and have experienced any of the following: persistent, unexplained, elevated PSA, prior negative biopsy, increased prostate cancer gene expression, a PCA3 urine test with an elevated score, and apparent low-risk prostate cancer. Finally, a hybrid imaging method can be used in which an MR images are fused with real-time ultrasound images, an approach known as MRI TRUS fusion biopsy. This approach has the advantage of using the superior imaging of the MRI coupled with easier to use ultrasound guidance and can be done in the office setting. MRI targeted biopsies, which combine MRI images of suspected cancer with real-time ultrasound technology to target areas for biopsy, are better able to detect more high-grade cancers than systematic blind biopsies. NIH's National Cancer Institute carried out a study to determine whether it would be better to replace systematic biopsy with MRI targeted biopsies, or to use both tests together. They compared these methods on more than 2,100 men who had MRI visible lesions. The study was funded in part by NCI and NIH's Clinical Center. Results were published on March 5, 2020, in the New England Journal of Medicine. The combined biopsy provides more accurate diagnosis. Among the men who underwent prostatectomy, systematic blind biopsy alone underdiagnosed about 40% of the cancers. MRI targeted biopsy alone underdiagnosed about 30%. The combined biopsy underdiagnosed only 14.4%. With the addition of the MRI targeted biopsy to systematic biopsy, lethal cancers within the prostate can be identified earlier, providing patients with potential for better treatment before the cancer spreads. Gleason Score. The tissue samples are then examined under a microscope to determine whether cancer cells are present and to evaluate the microscopic features, or Gleason score, of any cancer found. The pathologist assigns a grade to the most predominant pattern of involvement of tissue examined, and a grade for the secondary pattern, or second most predominant, based on published Gleason criteria. The Gleason score is the sum of the values of the Gleason primary and secondary patterns. A low Gleason score means the cancer tissue is similar to normal prostate tissue, and the tumor is less likely to spread. A high Gleason score means the cancer tissue is very different from normal, and the tumor is more likely to spread. Gleason score, PSA, and digital rectal examination together determine clinical risk, which then dictates treatment options. Computed tomography, CT scan. A CT scan uses X-rays to make detailed cross-sectional images of the body. This test isn't often needed for newly diagnosed prostate cancer if the cancer is likely to be confined to the prostate based on other findings, such as DRE result, PSA level, and Gleason score. Still, it can sometimes help tell if prostate cancer has spread to nearby lymph nodes. If the prostate cancer has come back after treatment, the CT scan can often tell if it's growing into other organs or structures in the pelvis. Bone scan. If prostate cancer spreads to distant parts of the body, it often goes to the bones first. A bone scan can help show if cancer has reached the bones. For this test, the patient is injected with a small amount of low-level radioactive material, which settles in damaged areas of bone throughout the body. A special camera detects the radioactivity and creates a picture of the skeleton. A bone scan might suggest cancer in the bone, but to make an accurate diagnosis, other tests, such as plain X-rays, CT, or MRI scans, or even a bone biopsy, might be needed. This is a list of the sources used in this presentation. If you have any questions, I can be reached at our toll-free 1-800 number. Thank you for viewing this YouTube presentation on diagnosis and screening of prostate cancer.